Hello, everyone. Welcome to this track. Please have a seat.
Good morning, everyone. So welcome to the AI for Life track. I'm Aziza Merzouki, lead scientist at the Geneva Digital Health Hub, and I'm very happy to be your co-master of ceremony for this session alongside with Stéphanie Trang. So Stéphanie is the partner and general manager of Artefact Open Innovation Switzerland, and also founder of AI for Health. So together we will be guiding you through a series of keynotes, discussions, and pitches around the transformative role of AI in digital health. And I will, to kick off this session, I will now hand it over to Stéphanie.
Thank you, Aziza. So yes, the initiative that we will talk about during this 1 hour is AI for Life. So good morning, ladies and gentlemen. It's a true pleasure to welcome you at this track. Thank you for joining us in this inspiring journey during 1 hour at the intersection of artificial intelligence, health, and human potential. We are gathered here because we share a conviction. Artificial intelligence empowered by high quality data is just not transforming healthcare now, it is redefining what it means to live a healthy, fulfilling, and a long life. AI for Life's mission is to democratize the benefits of AI and data in the fields of prevention, well-being, personalized medicine, and longevity. Today, as we look around this room, we see innovators, clinicians, researchers, entrepreneurs, policymakers, investors, and patients, all united, I guess, by a shared vision to harness technology for a betterment of life itself. Over the past 2 years, the pace of innovation in these sectors has been nothing short of extraordinary. In prevention and well-being, AI-powered wearable devices have moved far beyond simply tracking steps or heart rate. AI is enabling truly proactive care, empowering individuals to take control of their health like never before. In personalized medicines, just in the recent year, we've seen breakthroughs in using AI to predict patients' responses to treatment, making medicine more precise and more effective. In longevity and healthy aging, AI is opening new frontiers. The latest research shows that AI-driven interventions, such as personalized coaching and digital therapeutics, are already reducing the risk of chronic diseases and improving quality of life for older adults. But this journey is not just about technology, it's about people. It's about empowering healthcare professionals with better tools, supporting patients with accessible solutions, and ensuring that all advances are ethical, responsible, and inclusive. Switzerland, and Geneva in particular, is an ideal place for this movement. Here, we have a unique ecosystem that brings together world-class academic research, pioneering startups, global organizations, and forward-thinking public institutions. AI for Life is proud to be at the heart of this ecosystem, working to connect all stakeholders who matter so that together we can drive real impact. As we open this track, I invite you to imagine a future where health is not just the absence of disease, but a dynamic state of well-being, supported at every stage by intelligent, compassionate technology. Let's use this time to share ideas, challenge boundaries, and build partnerships that will shape the next chapter of healthcare. Thank you all for being here. Welcome to AI for Life track and enjoy the conference. Now, I'm calling Professor Annie Hartley. She will make a keynote on responsible implementation of AI in high-stakes clinical decision making. So Professor Annie Hartley is Director of Flight, Harvard School of Public Health, professor also at EPFL. Welcome her.
Okay, well, thank you very much for the introduction. And also, I want to take a few seconds of this very angry-looking timer to also thank GD Hub. I always love coming to the events, and they somehow filter out from all the blah blah that can go on in these places, people who are actually getting stuff done and who are interested in working in the field and are practical. So I love coming to these events because I'm always learning things from people who are working here, and it's an incredible job that you guys are doing. So thank you very much. I love keynotes as well because we get to zoom out, but hopefully not zooming out to the level of blah blah. So yes, I'm leading actually this lab called LIGHT. It's the Laboratory for Intelligent Global Health and Humanitarian Response Technologies. And what we're trying to do is make AI tools specifically adapted to low resource settings and also high stakes environments, volatile conditions. We work a lot with our partners at ICRC. I see Javier's in the room, you see. Great people just filtering into these GD Hub events. So yes, and it's really actually challenging to make these tools adapted to these very difficult high stakes environments. So I just wanted to give some pragmatic kind of tips that we've learned along the way, and also to understand how we can make it responsible when we are implementing these tools. So, and then hopefully, even if I have time, I mean, this is a very angry looking clock, but if I have time, I will also then give you an example of some of the demos that we have. So it's exactly what it says, right? I'm first going to cover this in orange. I'm going to do high stakes clinical decision making. What is that? And then we'll go to the second part, which is how do you responsibly implement it, right? It does what it says on the box. And then, as I said, if I have time, I'll show you some of the platforms that we're making that fulfill some of these criteria and are working toward them, and that we're implementing as well right now. So let's start with some definitions then. What is a high stakes clinical decision? It's obvious in some ways, of course. What does it mean? It obviously means a high stakes, just the synonym is that it is high consequence, right? These are life and death decisions where there is a small margin for error. Okay, that's just the basic dictionary definition of a high stakes definition, or a high stakes situation, right, or decision. And so what's more important is in the places that we are working in global health, obviously, it's that smaller decisions are more consequential. This happens in fragile settings because there's no safety nets, right? So if you get something wrong, you don't have a supervisor who's going to catch it and slap you on the wrist and go, well, you better not do that next time. Right? There's limited resources, so you don't have the diagnostic tools that you need to make sure that you're making the right decision. And you don't catch the things that may be slipping under the radar unless you're hyper alert and vigilant and experienced. And you may be in a remote setting, so the obvious situation where if you make a wrong decision and you waste time, there isn't a backup plan. So smaller decisions have got much higher consequences, and this means that we have to be more vigilant about decision-making in low-resource settings. So high-stakes decisions are not just all bad and all risk. Of course, it's a trade-off. It's high risk, very high reward. It's a decision point that is defined as having the highest potential impact. And so lots of people will say, well, you shouldn't implement AI in these kinds of situations. But you can argue equally that if you do have some evidence that these tools are working and that they can work, that you have a responsibility with equipoise, with that genuine point of being genuinely uncertain, that you should intervene in these environments with technology that has a high potential to work. So in these settings, right, what's nice about it, another positive thing, it's not just that it has high impact, it's that in these fragile settings, what defines global health, right? It is a place, or like, let's say, it is a study of trying to prevent preventable disease, right? Or preventable death, We know that it's preventable, therefore we know that it has a solution, and we know these decisions that we should be making, and therefore it's very low-hanging fruit. So it's a lot less uncertainty. So we've got very high stakes, very high decisions that are like high-risk decisions that we have to make, but we also know what decision we should make most of the time to have that impact. So it's kind of obvious, but I wanted to get through that to make us sure that, you know, that's our ethical approach to deciding to intervene in these interventions, in these places, right? And now if we go to the second part of this, it's more about, like, now that we know what a high stakes decision is, to focus more on how can we responsibly implement AI in these volatile environments. So the first thing is, I think is most important, right, is that we have to do this with vigilance. And vigilance is a really important thing, because I think you've had a lot of people speaking maybe on panels and stuff this morning as well, but, you know, like cognitive atrophy of when doctors are using these tools and then they just get lazy and then they just start relying on them and they don't really understand when it's making an error and they rely on them too much, and then there's this problem with responsibility and etc. But that only happens when we give people a false sense of security of when the tools are going wrong or not. So we have to have vigilant and aware both users, but also systems. And there's ways to ensure that our systems are built with that vigilance inside as well. We can make hypotheses about when biases will occur. We can build in fail-safes to ensure that the tools are understanding. And I mean, there's some new really interesting technologies just being much more pragmatic. Agentic systems is quite a buzzword at the moment, but it's also extremely helpful. We can have several large language models, for example, looking at a situation and decision in several different ways and coming to a consensus. This kind of consensus decision-making is very expensive in medicine. And so we have lots more opportunities to make decisions with that kind of groupthink approach. We also have this LLM as a judge to kind of judge our decisions or judge between two decisions. And this kind of system can also be used in an agentic system when you've got a whole lot of different large language models, for example, telling you and driving you into a certain direction from different viewpoints. But with our users, it's really important, right, to make sure that they are vigilant. We can't just say, be vigilant, right? We have to make sure that we give them evidence, and we have to nuance their trust with that evidence. We have to give them evidence in a way that they understand. And that evidence can only really come with experience. So you can't just go and deploy a tool in a population that's never used it before, or in a population where it's still a bit taboo, or where it hasn't been integrated into clinical workflows. You have to build that trust in visual cues that they can understand, and make sure that you actually integrate their feedback into the models. And so this co-development through expert evaluation is, all of your users will have an opinion about how the tool is performing and how it's helped them in the clinic. And that is critical to integrate it, and we can. For the first time with these large language models, is a conversational interface. So we can actually take experts' opinions and bake it back into the model, and it makes them not only vigilant about how the models perform, but it makes them part of the evaluation, part of the development of the tool, and owning the tool. And therefore, their responsibility of how the tool performs is shared. So this is kind of this responsibility of the responsible implementation is really important, because it can only be done through vigilance and co-ownership of the decisions that are being made. So the second thing is really about transparency. And I know this can sound a bit like high level, and you go, oh, well, it's going to blah, blah. Everyone's saying the models should be transparent, but there's actually a lot of things that you can do practically to make sure that these models are transparent. We can demand that the tools that we are using are open, but open in many, many different ways, very practical ways. These are things that you can ask the vendor to do. You say, I'm not going to use this until what? Until I know what data you've trained on. From the training data, from the instruction tuning data, from the RAG data set, which is this retrieval augmented generation, these things should be released. You should know what the model is pulling from, right? You should have open models. Models should have open weights, but also open checkpoints. We should know when the model started overfitting. We need this checkpoints is like when the model is training, how is it progressing in its training? We should actually also know, which is often not released, the system prompt of the model. What instructions were given to the model after it was trained to say, hey, every time you maybe see this word, just give this drug's name, right? We want to see if any instructions were given to the model in particular to see how it performs and if we can intervene at that level as well. And finally, we also need open decisions. You may have heard with like, let's say like DeepSeek that came out recently. You might have heard of reasoning models in AI. It's this way of like engaging with the model and seeing how it came to that decision. It's called a reasoning trace. And these are very helpful. They're not always 100% truthful to how the model has made its decision, but it allows logic alignment. It allows a user to understand how someone got to that decision. We, of course, need citations, and these are increasingly possible with these generative algorithms. And most importantly, and this is where our tools are coming in, we need open evaluation. If someone is coming to you in your clinic and saying, we have the best performing large language model in the world, you know, you and everyone else. Why? Because everyone can evaluate the way they want. And we have to start coming back to these people who are saying this and simply asking them to prove it. And this is really important, that we have ambitious investment in this neutral evaluation space, where we can take kind of an authority of evaluation, such as academia, some NGOs, maybe like some the neutral bodies in like WHO, if they have the capacity, or others, so that we can make the space for evaluation to occur. So expertise can come into the like an evaluation kind of battleground, right? And in a blinded way, assess the models. So you'll see that if we have time, I can show you a platform that we've made called a massive open online validation and evaluation platform that we're working with several governments and other university hospitals around the world to allow them to have these kind of LLM battles so that they can see which model is best for their setting with open evaluation. It's which model is best for their setting, which model is best for their specialty, which model is best for their specialty and their setting based on criteria that matter to them. Maybe they care about empathy, maybe they only care about accuracy. But these kinds of open evaluation criteria should be things that they decide themselves. And that's about responsible implementation and responsible evaluation. Then something that's really important that hasn't really come to play recently, it's been very difficult to find any studies that are doing this, is that the evaluations should be continuous, right? It shouldn't be one source. These are not frozen models. Machine learning is supposed to be continuous. It's the ing in machine learning, right? These machines are designed to continually update themselves and learn without being explicitly programmed. And it's a shame, and it's also wrong for us to ignore that they can do this. So we should update them. And so we should build the models in a way that they can be deployed in this continuous learning environment. Train people to understand that the models have to learn from them and they have to teach the models. And we should also remember that we have to collect real-world outcomes to ensure that the model's learning from something that's real. The real consequences of making decisions in low-resource settings means that people will sometimes die because of a decision. And that's really important information needs to get fed back into the model. We have to operationalize the evaluations, operationalize the outcomes to make sure that we actually learn from our mistakes. And finally, it's really important that it's participatory. We said before that it's important to have a human in the loop, but it's important that they are contextualized as well to make sure that we've got that human that can understand the local context. And finally, this last part that I put up here is that we shouldn't make the same mistakes as the previous mHealth kind of model did, where everyone did their own little vertical project. So you had like a model for maternal and child health and a subset of that and a subset of that. And everyone had our apps were just like overflowing on our phones as doctors. It was really difficult to understand which one to use and which one was evaluated. Here we have an opportunity with large language models to have a horizontal use case to come together over one cause and to make large scale, massive scale initiatives that are actually coordinated between different places. So yeah, I do just have like 1 minute, so I'm going to be naughty and I'm just going to go ahead and show you 2 platforms. The one is Meditron and the other one is the Move. And it's a pipeline for some of these words that you've said before, like I've said, you know, like contextualized, continuously learning, grounded in clinical validation, participatory. So what is Meditron? Well, basically it's a suite of open AI chatbots for medical knowledge adapted to resource limited settings. And the Move is a massive open online validation and evaluation platform to take those models that we are making. So we make a suite of these evolving models, and then we can take those models because they'll never be perfect. And we just accept that and we're vigilant about that, right? And we allow them to be moved to their new context through this evaluation and this constant feedback. So this continuous learning cycle is what we're interested in. The models, well, they're an evolving suite of models. So if DeepSeek comes out, we can medicalize the models. It can be in different shapes and flavors. It can be with any kind of base model, and it can be on your phone or on a server. Meditron has become a pipeline to make these. And the Move, well, how it works is it's participatory. We ask doctors to gather their colleagues. We ask them to ask our chatbots difficult questions, and any chatbots, not just Meditron, then to rate and correct the answers. And then they get everything back to them as they should. Their data so they can publish papers, as well as the models themselves that they've learned to contextualize. So as you are asking questions, as in this last few minutes, I will allow the thing to play behind me, and you can see how intuitive it is. And there you've got a live kind of demo in the background. But by the way, we're also last thing. I'm not going to say it. I'm being very rude by going over 30 seconds. But we're doing large scale clinical trials as well, which fulfills a very important part of our study, which means that we're collecting real world outcomes as well, so that we can feed those real world outcomes back into the model using this platform. Here we're asking fake questions. The next step is asking real world questions, and then in the hospital as well. Okay, so I'm going to leave it there, but I was very naughty, so I'll stop. But thank you very much.
Thank you very much, Professor Annie Hartley. Thank you. Now we will listen to Dr. Jose Antonio Ruiz Postigo. He's the medical officer of neglected tropical diseases at WHO. Welcome, Dr. Jose Antonio Ruiz. Please applaud. The title will be Artificial Intelligence as a WHO educational tool for primary care workers dealing with skin diseases.
Thank you very much. It's a pleasure to be here. Thank you to the organizers, and thank you for all those who are here and online. So let me show you briefly what's the tool, what we have till now. We have an app that is publicly available in Google, for Android, for iOS. That one doesn't have the component of the artificial intelligence, and we have a beta version. It's the one I'm going to show to you. It has 2 algorithms based on AI. They are visual classifiers. One is specifically and only for the so-called skin neglected tropical diseases. It's a list of about 12 diseases declared by the World Health Organization. This one was developed by Universal Doctor, but the algorithm belongs to WHO. And the database, the photo library, some 10,000 images that we have used to train the algorithm are also with WHO. We have a second algorithm. This is for common skin conditions. We have around 1,500 conditions there. But we asked the developers, a company called Bell AI, they are the ones that developed, and they own the algorithm, and they own some 400,000 images. We asked them to narrow down that list of plus 1,000 diseases to only 24 that are the most common, the commonest in the context, the settings of low and middle income countries, and mainly in the tropics. So basically you take an image, a photo, you upload your photo. In this example, there is a patient that you may suspect atopic eczema, and then by chance the app tells you that this is what is suspected, but there will be always other conditions, because the differential diagnosis, the list of possibilities, is the target. This is not a medical device. This is like an interactive book for you to get the list of the differential diagnosis. What we have done to test it in the field, as Annie said, well, we went to Kenya, we went to 5 counties, we involved 40 frontline health workers, nurses, community health workers, a couple of medical officers. And I'm just here showing one of the indicators, the recall. And interestingly, for both algorithms, which are at the moment independent from each other, the sensitivity was around the same, was 80%. And very soon we are aiming at publishing the details of this sensitivity, because it ranged from 0 to 97% in 4 cases. And the gold standard was to compare the image, the results of the AI, against 3 board-certified dermatologists. What I want to emphasize here is that the way the tool works and the 3 dermatologists also work is that we are only assessing the image of the lesion. We don't have information about the clinical signs or symptoms, which of course in the real medical practice you will have to add. Once you have a suspicion because you see a lesion, then you have to talk to the patient and you have to examine. But so far the tool only works on the shape of the aspect of the lesion. We also interviewed the health workers who use the app, because it was not only about measuring the accuracy of the app, but also the impact in how they felt. We used the mobile app rating scale, the UMARS, and we obtained a mean of 3.82 out of 5. And here you can see the 6 dimensions that we assessed. And during the focus group discussions, we obtained, or they gave a score of 8 out of 10. So my last slide, what is our ask? Why we are happy to be here? Because as you said, these tools are far from being perfect. We need a multidisciplinary approach, clinicians, engineers, people from the low and middle income countries, academia, to ask us to improve it, to probably test an offline visual classifier so that we don't need internet in very remote areas in the tropics. And it's always challenging to find images to train the tool. Thank you.
Thanks a lot, Jose. And thank you also for our previous speaker, Marianne Hartley. So we will now continue with 2 solution pitches. First one is from Dr. Fulvio Michelis, who is Strategy Director at Merck for Digital Health and Analytics. He will be presenting on enhancing growth hormone deficiency treatment, the global impact of the AI-enabled GrowZen ecosystem. Please welcome Fulvio.
Hello, everyone. Thank you very much to the organizer for inviting us to speak. I'm Fulvio Michelis, and I work for the pharmaceutical company Merck, and how it's known in around the lake, Merck Serono. I won't bore you with slides today. I want to tell you a story. I want to tell you the story of Sophia, one of the patients that I recently interviewed. And she was diagnosed very recently with growth hormone deficiency. Her story is honestly unremarkable. It's very similar to the story of the tens of thousands of patients that we treat every year for growth hormone diseases in general. And the first thing she said when the interview started was that she was relieved about her diagnosis. I was quite surprised. And yeah, she was relieved to know what was wrong, to use her words, with her. But at the same time, she shared the anxiety about a disease that she didn't know, a treatment that would last several years from her childhood into her adolescence, and also the burden of a daily treatment that impact really her daily life, because she has to inject every single day. So what can we do as pharma companies to help Sophia, but also all the other patients that we have, to and help them in their treatment journey? Well, we have developed a full ecosystem with hardware solutions and software solutions. On the hardware side, we have an automatic injector that helps patients to set their comfort settings, the depth of the injection, the speed at which the drug is delivered into the body, but also that sends data to the software part, the mobile application, and the portal for HCPs to know how the treatment is going, to provide educational support to the patient, caregiver, and HCP, and also track the outcome. And we demonstrated that this full ecosystem really helps. Patients that are engaged in the ecosystem are more adherent and also grow more. But this is old story. Why am I here to talk about AI for life? Well, AI is really our next step. We demonstrated that digital can help, but AI can bring us really to the next level. And how? Well, we have millions of injection and records of tens of thousands of patients, and we demonstrated that we can detect soft signals of non-adherence well before patients are non-adherent. So with the full ecosystem and this real-time knowledge that comes from the auto-injector and the use of the app, we can screen patients that will have problems of non-adherence and help them at the right time with the right content and support them in their treatment journey. So at the very beginning, the problem can be fear of needle, or later on in life, toward the adolescence, the fact that they want independence in their treatment, or treatment fatigue. Well, we can detect these soft signals and help the patient. Another thing we demonstrated is that we can predict growth, future outcome, with a few data points, and providing HCP with the prediction of growth and the soft signals that we detected, we can help healthcare professionals to be more knowledgeable, more empathetic, knowing what's wrong with their patient, and hopefully take better decisions. So what is the conclusion of all this? The conclusion is that as pharma companies, we can support healthcare systems with better knowledge, help patients and caregivers, and really AI can bring this support to the next level with personalized medicine in all across the world. And our solution is really scaled to 40 countries across the world, and we see the impact that we bring to every single country we're in. Thank you very much.
Thank you very much, Fulvio. And also thank you for sticking to the time. It was perfect. So next up on the stage is Mr. Mohammed Sarfarazul Ambia, Chief Data Scientist at Kushi Baby, sharing their work on AI-based anemia screening tool. The floor is yours. Please welcome Mohammed.
Yeah, hello everyone. Yeah, so myself, Mohammed Sarfarazul Ambia. I am the Chief Data Scientist at Kushi Baby. So Kushi Baby is a digital non-profit organization supporting the various states of India. And today I'll be speaking about a project called as Mahila. Mahila in Hindi means woman. And this project is all about, can we predict women to be anemic based on the images of eye conjunctiva and tongue. So yeah, in India, around 12 million pregnant women seems to be anemic. And the issue is that there's a risk of increased maternal mortality, right? Luckily, we know that anemia can be reversible with a proper and supplementation. But the challenge is that to identify those individuals who actually needs the intervention. As you can see it over here. So this is the real challenge when it comes to the ground reality, identifying those pregnant women who seems to be anemic. Now we know that WHO rapid test and the lab test are pretty expensive and invasive. And also in India, it's cost around like annually $50 million. And even after that, 10 to 20% of the anemic cases gets missed out. So we did ask the questions to ourselves. Can we build a solution that can be equitable, affordable for each and every one? And that's where the concept of smartphone did arise. So how about a health worker, just by clicking on the images, will she able to see whether a pregnant woman is anemic or not? Okay, we thought this would be the approach. So then what we tried was, as you can see over here, there's a study going on one of the states of Rajasthan. The initial study sample is 3,000. We have collected so far 2,500 samples around it. We finished our preliminary analysis. Our approach was from the overall eye image, we tried to extract the eye conjunctiva and fit it into the model. And initial results are pretty promising. With all the evaluation metrics, be it sensitivity, specificity, or even the F1 score or AUC seems to be above 0.9. And this is kind of one of the largest study in the world. So what are our next steps that looks like? So this is the initial results that we have got. So our next steps are crystal clear. There are three major objectives. The first one is to validate these models across different demographics. And thankfully, our two more studies have been approved across two different demographics in India. So what we'll be doing is that we'll be validating these models across 25,000 pregnant women. That's the first thing. The second goal for us, this model should not be working just for the pregnant women. Can we also build a model which will work for the general population? Third, and the most important thing, whether the model can work in the varieties of smartphones, creating a benchmark performance. So these are the three major goals for us when it comes to these AI-based anemia screening. And we're also aiming to publish the foundation model, which is basically the end goal is making sure these models doesn't work just on the classification, but also works well in terms of regression. Our end goal after all these 3 studies is to make sure, can we accurately estimate the hemoglobin with a plus or minus 0.5 gram per dl? So closing remarks. So just imagine a health worker going door to door, and just by clicking on the images, if she finds out a woman is anemic or not. Just imagine a woman who not left out from the anemia screening. And that vision comes from this project, Mahila. And so far in my 10 years, I would say this is my most important one. And finally, if you guys are interested to collaborate with us in research or even in scale up, or even in terms of the regulatory integration, we are happy to connect. Thank you all.
Thank you very much, Mohammed, for your presentation. Very inspiring to see how AI can drive diagnostic tools impacting so many women. You said 12 million pregnant women. So we will now transition to our panel discussion on exploring the role of AI in women's health and longevity optimization. So let me introduce our distinguished panelists. So first is Dr. Anna Erat, expert in prevention and longevity medicine and health optimization at Hirslanden. Second is Mrs. Anastania Georgievskaya, CEO and founder of Hout.ai, who brings deep expertise in AI-powered skin diagnostics. Third is Mrs. Corinne Brio-Manon, founder of Green Marlin Consulting, a leader and experienced in driving innovation in consumer health, longevity, and biotech at global companies. She's also the founder of Long Hair, Women's Health Span Initiative, which will be launched in New York City in June 11 and in Switzerland in October 11. And this panel will be moderated by our co-MC, Stéphanie Trang, who is partner and general manager at Artefact and founder of AI for Health.
Live.
Live, of course.
Thank you, Aziza. Welcome, so everyone, at this panel discussion about women's longevity. We will explore the role of AI in women's health and longevity optimization. Thanks to our 3 experts. Thank you very much to be here. I first will ask a question to Anna. Many studies and tools in health tech are based on data from men, right? How do you think AI can address gender differences and better adapt to women's unique health and longevity needs? Very curious about that.
Well, thank you so much, first of all, for having me here. It's really a great honor, and I think very important to have such a platform to exchange ideas and listen to each other and learn from each other. So it's really great, and particularly, of course, now also discussing gender and gender health and female health, and the importance of taking into consideration in a precision medicine world. I think we live in that world today. We should really also take into consideration, of course, sex and gender differences. So it's a great question. And unfortunately, as a medical doctor, I have way too often witnessed, for instance, in cardiac situations where people have had a heart, for instance, a myocardial infarction, where women just don't get diagnosed. So I have 2 friends, 2 colleagues who, in fact, knew or thought they had something. They went to the emergency room and they thought something was wrong with their heart. But a lot of times, as we know, women experience a heart attack completely differently than men. It might just be a bit of nausea or like stomach ache, and that's it. So it's not the typical radiating pain into the left arm and the jaw and the dull pain in your chest. It's completely different. And one of them was sent home and the other one died in the hallways of the emergency room. So that's why we need to learn to take into consideration and first of all design studies that take into consideration and integrate and involve women and various ethnic groups into the study. So it's not only about women, it's also about ethnic groups altogether. So precision medicine, personalized medicine should take into consideration these factors. And also age, by the way, various ages. And how can AI help us with that? Well, if we start with the studies, just by designing the studies, already there by the study design, AI can actually help so that we really design studies that adequately take into consideration gender and sex differences. Then while conducting the studies, particularly, and I really liked what Annie said about the real world data. I've always been a huge fan of real world data. I think the entire discussion of whether everything has to be a clinical trial or if we also should integrate observational studies, I think this discussion is hopefully over. Observational real world data is extremely important as well. And here, the data sets are huge and very complex. And here, of course, AI is a fantastic tool to analyze the data and capture patterns, which we as humans arguably cannot do that well. So that's when we then actually analyze the data. But then at some point, we also want to implement what we've learned. And so as a clinician, of course, regardless of how much experience you have, you still rely also on algorithms. And these algorithms or guidelines, they of course change as well, depending on what kind of studies and what kind of data we are capturing and receiving through research. And also in this case, of course, AI can be a huge important tool to improve also the algorithms and more quickly. So traditionally, these algorithms were based on men, particularly white men at a certain age, and which is important, I mean, without a doubt, but there are other types of people in this world as well. So also here to more quickly allow new updated algorithms and guidelines to be published is of course where AI can have a huge role as well. So I'm very excited. I think AI can play a huge role, and these are just a few examples, but I think very important examples.
Very agree. I think AI will revolutionize things if we have a better smart data, inclusive data, and real world data. Corinne, how do you see tools like health trackers, you have one actually, wearable devices, or personalized wellness platforms empowering women to take control of their health and have a better health span?
So I think Dr. Ehrmacht said it very clearly, right? It's critical to have more data on women, right? And yes, there can be clinical trials, but there's all these real life, data that you can get through these devices. So that's one thing, right? And I think we, whether you have an Oura ring, whether you have a Whoop bracelet, or any other, I think that can help, get all these data, which are for women, for men, but can definitely help with designing diagnostics trends, which can then lead to interventions, whether it's behavioral interventions and whether it can link to treatments. I think it's always great. I think the other thing that all these trackers, platforms can do is it can also help with addressing two main barriers women face when it comes to health span. First, it's access to healthcare. So you can live maybe in a medical desert, as we say in France, right? So accessing a practitioner might not be easy. But also numbers are very clear, right? Women tend to deprioritize their health. And when I say that, they tend to not go to regular checkups, health checkups, as early and as often as we should, right? They have many priorities to juggle with. I think we are too good at multitasking. But I guess that's one thing, right? So they might delay some of these health checkups, and that these health checkups can check for diseases which can have a big impact on their health span. So that's one thing. The other thing as well is that women tend to feel dismissed by their medical doctors. Not all of them, of course, but there's very high numbers about that. In the UK, more than 80% of the women say that they went to the doctors and felt dismissed when they were talking about maybe not the cold and flu, but other symptoms. And so these devices, which track, behaviors, which track, your lifestyle, can help equip women for the right discussions with their doctors. They can also help them think about preventative measures they should be putting in place. They can remind them to go and see the doctors when they see that maybe, their heart rate is, a bit different from one day to another, or from one week to another, right? We're not talking about clinical trials here, but we are talking about behavioral changes, right? So it can lead to women, putting in place some measures in their life, lifestyle measures. And we know lifestyle measures have a massive impact on health span. You may have good genes, but your genes only impact 15 to 20% of your health span. The rest is really your lifestyle, the behavioral changes you do through nutrition, sleep, exercise. So having a health tracker can help you monitor, can help send some reminders to you to have a break during your day and lower your physiological stress. And it all has an impact on your health span long term. The other thing as well is that it's going to empower women, get education and get care. So there's a very big platform in the US, which is called MIDI Health. It's a platform specialized for menopause, right? And it's basically a platform that women can access extremely easily. They are going to get advice from their doctors. They can get prescriptions. They can get treatments. They can also, look at blogs and understand better what's happening to them, right? So I think there's this empowerment that women can get. Again, that makes them equipped to have the right discussions with their doctors, because then there's a need still to do that. But it's also helping them, to feel some support when they are facing some, symptoms that they are not used to. They don't know what's happening to them. So education and care.
Thank you, Corinne. Very useful to understand what is the impact of wearables in our behavior change and lifestyle for women. Talking about beauty, Anastasia, in your experience, what are the biggest misconceptions around personalized beauty and longevity? And how companies like yours address these gaps to truly empower individuals in their health and wellness journey?
Yeah, thank you so much for the question. I think when it comes to longevity and beauty, for a very long time, we thought that it's very fragmented. We're acting like, a story about a blind man trying to define how an elephant looks. So a blind man first interacts with the elephant, but they don't know how it looks. So we try to touch it and then come out to the consensus what elephant is. So some would touch the trunk, some would touch the tail, the legs. And essentially everyone says, oh, it was a snake, or it was a rope. The legs felt like a tree trunk. Essentially none of them was right. So in the beauty and wellness, we see this more holistic approach. So instead of looking at only one aspect, like your mTOR pathway or your inflammaging, we start realize that it's more holistic process. And the good confirmation to that is that there are so many longevity theories of aging, but there is no dominant theory of aging. Why aging happens. No one has yet solved what aging is. Same comes for beauty. You genuinely will see a lot of trends with companies like Kenvue, Unilever will now go into longevity and wellness. That's a logical expansion for them, because not only because we want to capture new market, which I'm sure they want, but essentially because they also understand that consumers will not have good skin outcomes if they are not treating it holistically, like their wellness and sleep and their allergies. So all of that has to take into account. So then we are starting to collect more data, right? What has impact on our skin and our longevity. We collect a lot of data. And then there is also general consensus that the more data is the better. But the more good data is better, because if you have a lot of data which is essentially garbage, it's like very unstructured, you really are not benefiting from it. So I think what AI can start doing is even doing a better data preparation and cleanup, so that not only we heard a really good presentation before about feedback loop with the humans. So essentially AI can get us some human clarity on our data, so that we are able to discover new insights for wellness and longevity. And I think that the companies in the space of AI and wellness are, first of all, by their activity, they're driving investment into the field. More and more people are interested in the field. Great minds come to the field. So they may work in these companies, then they're going to go find their own companies, or they're going to, propel that AI excitement and, belief in AI. So it, of course, will help the industry develop. But I think the biggest advance for AI companies right now is to really look at this holistic data and start thinking of really helpful applications. For example, in our company, and we are developing AI solutions for skin analysis, we are looking more at the concepts of long memory. So while consumers interact with our software, whether it is a face scan or chatbots, we essentially want to remember them so that we don't have to prompt every time the system. And being able to not only have a lot of the data, but structure it logically, and being able to have a timeline of important data highlights, I think what will also help not only AI systems learn, but it will also help human professionals making discoveries or make new studies and drive also the scientific frontiers in the space of longevity.
Thank you, Anastasia. Now, to finish our discussion and all this conversation about longevity, I want to ask you all three a question. What advice would you give to women on taking control of their health? And what societal change do you believe is most urgent to support women's longevity? Who wants to start?
Yeah, logical. So I think, in my view, women should prioritize building lean muscle mass, and I will explain why. So first of all, it's, as Corinne said, we usually deprioritize ourselves. So building lean muscle mass is not only associated with a longer lifespan and health span, which is also more important, but essentially it's a commitment that you make to yourself, taking time to yourself. It's not like you can exercise, 3 months and then stop exercising. You will going to lose it. So essentially this is like a long-term commitment to your health. And generally, I think that prioritizing your checkups, showing up for the appointments, tracking your biomarkers, longitudinal is what you have to commit to, but their outcome and the gain is the highest compared to, let's say, some inconsistent or not really recognized as having credibility methods to support your lifespan and health span.
Thank you, Anastasia.
Thank you very much. Well, as a sports physician, of course, I couldn't agree more with both of you. So muscle mass and healthy muscles are extremely important, particularly for women. I mean, for men equally so, but women tend to not prioritize it as much classically, traditionally. And coming from the field of research that I did, where I looked into chronic inflammation for many years in various settings, I, of course, believe that low-grade chronic inflammation is one of the absolute main drivers of aging. It's one of the commonly accepted 12 hallmarks of aging. I'm sure we will have other hallmarks of aging later in the next few years, but commonly accepted ones. But I believe chronic inflammation is one of the main drivers, and healthy muscle mass actually is anti-inflammatory. So it's really not only in terms of frailty and in terms of being able to get up if you fall and so forth, and not only because of aesthetics, but really also because of this anti-inflammatory mechanism. It's really worth paying attention to that. And it's not, as we already said, it's not selfish to pay attention to your health. A lot of times women tend to think that, well, if I take an hour or two to go and work out and take time to take control of my health, I'm kind of not taking care of the others that I should be taking care of. And that's absolutely a wrong approach, because you can't take care of anyone else if you're not somehow fit to do that yourself. So really, it's really time to prioritize and not to feel guilty about, for instance, working out. And finally, as we know, the main predictor of the health span and a long, healthy life are social and meaningful connections. And so while you're doing all of this, also do it together with people you care about, people that you like. Take care for instance, also today, I mean, this is a great place to network and build meaningful connections. So prioritize that as well. Women and men equally so. So that's, I think, what is my take-home message right now.
Thank you, Anna. Corinne?
Yeah, can't agree more with everything which has been said. I think there's also a concept that women, grasps, with less ease than men, which is resilience is not grit, it's recovery. I myself, when I heard it the first time, I was like, what do they mean here? I think we tend to, as women, we tend to push resilience a lot through the fact that maybe we want to juggle with career, we've got kids, we've got, husband, we've got a family and all of that. And we tend to really push all the time, right? And we think we are resilient, which in fact is not the case. I'm working with an institute which is called Resilience Institute, and they have, analyzed a lot of, population, right? Men, women, all of that. And it's demonstrated that women have less resilience from a physiological perspective than men. And it's all because they push themselves a lot. So think about recovery, include recovery, in your daily routine, because it's critical long-term. It's linked to inflammation, it's linked to a lot of issues you're going to face. So that's one thing. The other thing as well is, we're talking trackers and all of that. So you can improve what you can track, but track what matters. So there's a lot of trackers or tracking measures you can look at, but really think and maybe talk to your practitioner as well to understand what really makes sense for you, because tracking a lot will definitely be very, very difficult, right? So pick wisely. I think there's one, but Anna mentioned, which is lean in community. There was a paper, there was an article in the news, in the New Science, I think it was a couple of years ago, which was about the brain in women and men. It's different. Okay, well, no big news here, I guess, but I think there's one thing which was really interesting, which is, women, need to have a community around them to, to thrive. And it's really linked to the brain, the way we process things, right? So a community is absolutely critical for women. It can be friends, it can be community you find online, but really, really think about that.
Thank you, you three. What I understand here is that we have to empower ourselves, thanks to tools, but also thanks to prioritize also ourselves as a woman. It was a very, very good discussion, a very important one. So thank you again very much to be here for that.
Thank you very much to our great panelists and for our moderator. I think the discussion was really thought-provoking and inspiring. So I think we all will get out of this panel with great advices, and we will try to follow that. So we will now resume with a fresh round of 2 solution pitches. The next one is from Dr. Shadi Saleh, founding director of the Global Health Institute at the American University of Beirut, and he will be presenting GAIN MHI, a scalable, innovative digital health solution for improving maternal health outcome. Please help me welcome Dr. Shadi Saleh.
Good morning, everyone. So I want to start off by saying perhaps something controversial, is that although we truly appreciate in the global health ecosystem and global health world all of the thinking and innovations that are coming from many institutions of the global north, including universities, including institutions, tech startups, and so on and so forth, it is very, very important to invest in organizations in the global south to do that, to figure out the solutions, because this is where the problems are. And in the latest assessments that the global south, and we're talking about Latin America, Africa, Middle East, Southeast Asia, there's talk that the gap in knowledge to adapt to AI solutions may be 10 to 15 years. So we may have all of those wonderful solutions, that are being thought of in North America and Europe and in other global North regions, but they're never going to be implemented in the global South if we do not invest in the capacity in the global South, if the solutions are not homegrown. So this is what we call global health colonialism. So we have just to be aware of that. We have to invest in that. We have to invest in the capacity in the global South. So we just need to make sure that speakers who come to these conferences and important meetings, the examples that are given, the people who are building all of those capacities are folks from the region. So this is perhaps equally important to whatever I'm going to say and during the speech. So I invested probably 1 minute and 20 seconds out of that my time, but it's worth it. Thank you very much. So to just put things in context, this is some of the statistics that we have out there in terms of the context of sexual, reproductive, and maternal health in Lebanon. You'd see that some of the numbers are quite alarming in terms of the prevalence of issues related specifically to reproductive health, but perhaps equally important is the number of refugee population within Lebanon. We're talking about a collective refugee population of approximately 2 million out of a total population of 4 million, so approximately 40 to 50%. To put this in perspective, folks who come from the US is 350 million, so imagine having a refugee population of 175 million. I guess, with the political atmosphere that we're living now, the Trump era wouldn't be happy about this many refugees coming in. If you want to apply it to Europe with a population of 750 million, imagine having 350 to 400 million refugees in Europe. So just imagine the dynamics and the pressure it creates on the society in general, but on the healthcare system more specifically. So what we came up at the Global Health Institute at the American University of Beirut is the GAIN-ME initiative, which stands for Gamification, AI, and mHealth Network for Maternal Health Improvements. And specifically, the application was in 19 primary healthcare centers. Beneficiaries were refugees and disadvantaged women and their spouses, because we found out from contextualized research in the communities that engaging husbands in the decision-making process in health in general and in reproductive health in specific is quite important and significant. The features is that it included a gestational age-specific messaging for women and spouses, so that's the mHealth component, and a significant gamification and AI-based mobile app for professional development, where the knowledge transfer is done and based on AI models in the back that always does the testing for modified testing for healthcare professionals, including upskilling, but in a sort of a gamification context. Main findings, we found that from an outcome standpoint, there was an increase of approximately 30% in experiencing on-term delivery and approximately 60% increase in the odds of experiencing neonatal morbidities. So this should not experiencing, so it's a decrease. From a process standpoint, there was a 57% increase in the odds of completing more than 4 ANC visit, which is the WHO recommendation, and an 82% increase in the odds of completing the required blood tests. So, and also from a process standpoint, more ultrasound. So again, from a process standpoint, from an outcome standpoint, there was an impact on both angles. And it was in our latest sort of analysis, it's the combo effect of the woman, the husband, and the healthcare professional, all of them doing that effect rather than one of them. So my last slide is our call to action is twofold. The first is scaling up. So not only the limited number of primary healthcare centers that we have conducted, but all of the healthcare system. and not only in Lebanon as a country, but also in other low resource settings, especially settings where we have vulnerable populations, and the replicability of this in different contexts, albeit with taking into consideration the contextual factor in each of those countries and working with local actors. I think, good, on time?
On time.
Thank you,
Perfect.
Aziza.
Thank you very much. Thank you, Shadi. So really interesting and inspiring talk about vulnerable and displaced populations. So next is a solution pitch from Mr. Jonathan Doens, research engineer at EPFL. He will tell us about DeepRR, an AI tool to automate respiratory rate calculations from lung noise. Please welcome Jonathan.
So I know that I'm one of the last obstacles between you and your lunch. So I prepared some few notes to make it as clear and concise as possible to preserve your brain calories. So here's an activity that I'll let you enjoy experimenting with during the conference. Try to count the number of breaths of a person near you for 15 seconds, then multiply that by 4, then compare this to two other values that are age dependent, and try to do this while looking casual and professional. So it's not easy, right? So now imagine having to repeat this process several times a day. Well, that's what clinicians do when they auscultate you with a stethoscope and ask you to breathe normally, and it's the last thing you feel able to do while they stare awkwardly at you. So what they need through this cognitive and memory gymnastics is your respiratory rate, which is an important vital sign that is indicative of certain medical conditions. What they don't need is to spend so much energy doing it. And that is what we set to correct with Deeper, namely to make clinicians do medicine, not math. So that was my first slide. And that's the second one. So what is Deeper? It's an algorithm that automatically computes the respiratory rate based on lung sounds recorded from a stethoscope in real time. And here is how it works in a nutshell. So I'm sorry, it's maybe a bit more technical than the previous talks, but I'm a data scientist, so I can't resist. The sound obtained from the stethoscope is transformed into a spectrogram, which is the beautiful image that you can see. It represents the frequencies over time. So the x-axis is time, the y-axis is frequency, and the brightness is the magnitude of the frequency at this moment in time. And the pattern of inhalations and exhalations is predicted by a deep learning algorithm. Okay, now it's, yeah, you don't see it so well, it's in black, but basically it's like an up and down curve that represents inhalations up and exhalations down. And finally, the respiratory rate is computed from the average period between successive inhalations. So there you have it, a respiratory rate computed automatically with no awkward staring and no mental math. How well does it work? Correlationally speaking, it works better than clinicians estimating it using the stopwatch method that I alluded to. And this is what is shown in the two scatter plots that you can see. On the left, each dot represents a 15 seconds recording of lung sounds of a patient. Don't mind the colors, they are not important. Its position on the x-axis represents the correct respiratory rate value. Its position on the y-axis represents the respiratory rate value predicted by our algorithm, Deeper. And the correlation between the correct respiratory rate and the one predicted by Deeper is 0.79. On the right, same setting, each dot represents a recording, and the x-axis is again the correct respiratory rate value, but what's different is the y-axis represents the respiratory rate predicted by clinicians using a stopwatch. And in this case, the correlation between the correct respiratory rate and the one predicted by clinicians is 0.50. So it seems that, so Deeper seems to work at least as well as clinicians on average. Now, is measuring respiratory rates the only task that can be eased away by a digital stethoscope? Well, we don't think so. And in fact, Deeper is part of a bigger project called the Pneumoscope project. And it was started in 2018 by the OneScope team that you can see at the bottom left of the slide. and Yannick from MIT is present in the audience. And so they developed a digital stethoscope that you can see here and on the slide, named the Pneumoscope, and that can not only compute the respiratory rate, but also predict the presence of respiratory diseases from lung sounds, and also measure the heart rate, the body temperature, and the blood oximetry. So it's like a 5-in-1 device, which is pretty awesome. And you can pass by us after if you want a demo, by the way. It comes with a neat and user-friendly app, initially developed by Giorgio Manarini, shown at the bottom right of the slide during his master thesis in our lab. And now it's developed by Gaspar Chevalius in the middle and his team in his startup Apic Studio. And the AI development of the Pneumoscope is done by our lab at EPFL called Light, which is directed by no one else than Arnie Hartley that you saw in the keynote at the start of this track. And if you're wondering, yes, she's doing many things, like many things. And the technical implementations are greatly done by Rijong here on the slide and probably in the audience and online. And what is upcoming is that we'll soon collect data to make an asthma severity model. We'll also collect data from more hospitals. So far, we have collected about 10,000 recordings from hospitals in Africa, South America, and Europe. And we are actively looking for new partners to use the Pneumoscope. So if you are working or in or know potentially interested hospitals, please reach out to the OneScope team. The contact details are on their website, onescope.ch. And we also plan to use it for telemedicine in the future. And the Pneumoscope is expected to be CE marked this year. And I have to conclude. So this was a pleasure to showcase our digital solutions to respiratory care, and more importantly, to definitely eradicate awkward staring from auscultations. And with that, I wish you all upcoming lunch and a great rest of conference. Thank you.
Thank you, Jonathan. Just before going to the speed dating phase, I want to introduce you Chidima Okoye. She will present a poster implementing and integrating lung health screening using AI-enabled technology in remote rural communities in Nigeria. Okay. Welcome her upload.
Yeah, thank you very much. Good afternoon, everyone. Good afternoon, everyone. Okay, my name is Chidima Okoye. Today, I'll be sharing our experience implementing AI-enabled X-ray integrated screening in remote rural settings in Nigeria. First, I want to thank the organizers for giving us this opportunity. Next slide. Okay, so just to like a background, Nigeria, you know, like the other low and middle income countries, we are faced with double burden of both infectious disease and the rising NCD cases. So in rural areas in Nigeria, basically the access to healthcare, access to digital like X-rays, conventional X-rays is really very limited. So we use the portable digital X-ray that is able to be taken to the remote rural areas. And normally you would just go for just TB, screen just TB, and provide none or limited access or referral for the non-TB component. But for this project, we screened for both TB, cardiovascular disease, and chronic respiratory diseases. And we were able to provide a referral pathway for the NCDs, because for TB program, we already had a structured pathway in the country that works in the remote rural areas, and access to healthcare is easier for the TB program. But for the NCD care, we had to develop a referral pathway to the tertiary institution where the specialized care is given. So we had first of all, like all of, as we have been saying here, the importance of community engagement. In rural areas, we had to do very deep community engagement to get the buy-in of the people to even understand how or agree to uptake the use of X-rays and use of AI-enabled X-ray. So we had great community engagement. We also had to train these communities and make them part of the project. So if you look at the results, you will see that 35% of all of the people that were screened, we screened over 12%, over 12,000 persons in the rural area, and 35% had abnormalities. But it's also striking to see that over 72% of these abnormalities were NCDs. Remember, primarily I work for Caritas Nigeria, we were looking for the TB presumptives and also that an established care for TB presumptive, but 78% of these people had NCDs, and they were referred to tertiary institutions for care. And you would see that just 12% of these people were able to access care. And the issues are very clear. One, when you're in the remote rural areas and this care are very far, financial issues of getting to that facility and even knowing your way around. So this made clear that as the world is looking towards how do we care for NCD patients, there is need for a solution that will address NCD care at PHCs, at primary health care level, because these are chronic diseases. Even for those who were even able to get to those facilities at the first time, they couldn't return. And these are diseases that you need to have constant visit with the facility. And since in rural areas, NCD care is not seen in primary health care centers. So I'm really excited during the earlier session, seeing solutions that are talking about providing cares that are very close to the primary health care session, or providing cares that communities can key into. So in conclusion, one, we saw that AI is very key and is helpful in providing health equity, because this AI was able to, the use of portable digital X-ray was able to be used in remote rural settings. However, there is also need for us to look at integrating NCD care in remote rural setting. And we'll acknowledge the Stop TB Partnership for funding this project. We thank Caritas Foundation who implemented this project, and Cure AI, who had the AI company that we used to implement. We're very open. I see that a whole lot of AI companies are in the room, and we are open to discussing how we can constantly improve and ensure that equity in healthcare is given to remote and rural community. Thank you very much for listening.
Thank you. Thank you for respecting the timing, Chidima. I'm now introducing a new format, actually, that will be moderated and presented by Charlotte Wilming, that she will come on stage from Farm Access.
Good afternoon, everyone. My name is Charlotte, and we're going to do the second round of speed dating. And it is with great pleasure that I would like to ask Paul Ricard from MedBrain Global to the stage to deliver its speech.
Thank you very much. Hi, everyone. I'm Paul. I'm the founder of MedBrain. Thank you so much for inviting us. So 50% of all of humanity, they have no access to an accurate medical diagnosis. And that is mostly due to a severe shortage globally in access to specialist doctors, but also a shortage in access to gold standard diagnostic tests, diagnostic machinery. So both of these types of resources, they have something in common. They're not economically scalable. It's not viable to place one cardiologist or rheumatologist or one CT scanner at every single primary care center of a country. So we built MedBrain with the following hypotheses at heart, that we could change the paradigm, the diagnostic paradigm, and we could actually build a solution that would have similar levels of accuracy, sensitivity, specificity that the gold standard, but that it could be consumed at near zero marginal cost. So in other words, that it could actually be viable to deploy it at every single last mile health setting of any nation. So we've built that solution. So MedBrain, what it is a clinical co-pilot, a navigator that helps guide the last mile healthcare professionals through each of the steps of the clinical process. So it helps them conduct an expert clinical interview, a standard detailed anamnesis, a focused physical exam, and so on. So through answering MedBrain's AI-generated questions, through answering MedBrain's smart interview, these users, they can reach an accurate triage decision, diagnosis, and management plan in less than 7 minutes per patient. MedBrain, it can work on any smartphone, and it can be deployed fully offline. No need for internet, so that we can access the most remote areas of the world. So the government of Nigeria, they conducted a double-blind randomized control trial, totally independent trial, in which they measured that MedBrain had a 92% diagnostic accuracy when being used by primary care nurses. But more important than that number, what they did find also is that there was no statistically significant difference between the diagnostic accuracy of a nurse with MedBrain, primary care nurse, versus the diagnostic accuracy of a specialist doctor, a senior pediatrician. And we think this is a huge innovation. Also, we have a partnership with the government of Ethiopia, in which we are currently pilot testing MedBrain, just as a pilot, in 50 different primary care centers. We've been doing that for a few months, and we're excited to announce that they have agreed to expand the deployment of MedBrain to 1,000 health centers by 2026. But we would like to go much beyond that. So we would like to say here today, please, anyone who can, please help us expand MedBrain across the globe by linking us, connecting us to governments of low and middle income nations, so we can join forces and together transform this world into one in which every single human being has access to the diagnosis that they need and they deserve. Thank you very much.
Thank you, Paul. And I think after our last speed date, Paul and the other ones will be in the back of the room. You can talk to them and learn more about their solutions. So next speed date I would like to present is Oseni Odrago from Moilab. Please deliver your pitch.
Hello, good afternoon. My name is Odrago Oseni. I'm a physician specialized in digital health. This evening I will let you know something about a project. The history behind this project is that one day I received a patient. The patient came late. He is from a village far from the city. And when we received the patient, the diagnosis was diabetes with complication. The patient lost his leg. Imagine what it's painful to lose your leg. It's difficult. What can we do to avoid this situation? Because of in community, we have community health workers who are the first point of care in low and middle income countries. I decided with my team to develop application for them and allow them to diagnose diseases, especially diabetes. And what we have is a tool which allows us to detect diabetes early, to detect diabetes by using mobile phone without internet connection and also with internet connection. The tools allow us to reduce the cost of care and transport and so on. And what is important with this tool is that in our system, we are using DRCS2 and AMR. With these tools, we can connect our system to DRCS2 and AMR and have a continuity of care of patient. That's why I suggested you to improve the tools by collaboration and pilot implementation. And I'm happy this evening because I find that I'm not alone. We have many implementation of screening tools, but the problem is that each person works alone. We have screening tools for lung diseases, we have screening tools for diabetes, we have screening tools for something else. What can we do to improve the healthcare services in rural area by using these tools? My solution is to have one application all in one. Maybe I developed application for diabetes, but in the near future, with collaboration, we will integrate all application in one system to allow community health workers in the field to diagnose diseases and avoid complication. Thank you.
Thank you, Saini. Thank you for that. So our last pitch will be from Ricardo Lampariello from D3 on better decisions saves lives.
Thank you. So let's start with the problem. Amira is a pregnant woman in Tanzania, and she goes to the clinics for her last consultations. She's diagnosed with high blood pressure. And then she's given pills and she goes back home. At home, she forgets to take these pills. So when the community health worker goes for her last routine visits before birth, and Amira reports that she has a headache, the community health worker thinks, okay, headache, common symptoms, you take a paracetamol, have some rest, and you'll be fine. If the community health worker had known that a few days earlier in the clinics, Amira was diagnosed with the high blood pressure, the two pieces of information together is actually a strong symptom for preeclampsia, and you should be immediately referred to the hospital. So the community health worker, despite the fact of that, didn't have the complete set of information. So Amira and her child died. They died despite the fact that the facility level in the clinics, there was a good quality of care. There was a good quality of care by the community health workers, but it was not the people-centered approach to care, because they didn't have the full set of information to actually take better decisions. So D3 works to make this happen, works to actually have for everywhere you are in the primary healthcare system, the full set of information to take better decisions. So we integrate horizontally across health services and vertically across levels of healthcare systems and over time. The result is that wherever you are, you receive a better decision, the right care at any time, any point of care in the primary healthcare system. And these are the results that we get. These are only a couple of ones, so much better accuracy in treatments, the full referrals. And we do that in mainland Tanzania for maternal, newborn, and child health. And we do that using existing digital health information systems. And now we work on NCDs by using the same approach, people center care, and we are exploring mental health. Finally, in Zanzibar, together with our partner Reach Digital Health, we want to go farther. We want to reach individuals so that we empower individuals to take better decisions, have the agency, and then perhaps next time Amira will take the pills and save her life. I'm here to actually meet other partners that have a similar experience and share lessons learned. Thank you.
Thank you, Ricardo. And with that last pitch, we close this pitch round. But I do want to emphasize that if you want to have a closer look at the pitches, go to the website of DCCC and you can find more information on that. And Ricardo and the other ones will be in the back of the room if you would like to have more information right now. Thank you and have a nice lunch.
Thank you, Charlotte. So thank you, everyone. Everyone is angry, so I will let you go. But I just wanted to wrap up and want to thank you all the today's speakers, panelists, and especially our audience for your energy and engagement. I truly believe that the future of digital health is being shaped by the people in this room and with the brilliant innovations we've witnesses today. Now you can have and grab a lunch. There will be workshops this afternoon. The lunch is at the forum, so please go to the forum to grab a lunch. And if you want to participate to the workshop, there will be people who will guide you just right after your lunch and guide you to the workshops. Enjoy your afternoon. Bye-bye.
Thank you very much. See you.